Our presentation from our CCC19 consortium, presented by Dr. Jeremy Warner from Vanderbilt University, is looking at the impact of COVID on outcomes for cancer patients in a very large, very unique database developed by a very unique crowdsourcing effort just over the last less than 3 months, really started in mid-March, to really assess the risk factors, the major risk factors impacting cancer patients that contract a novel coronavirus infection. This whole effort started in mid-March. A resident brought us together on social media, believe it or not. Several of us key players were talking about wanting to start a formal registry to assess what is the impact of COVID-19 on our cancer patients, because there have been early reports that cancer patients are at particularly high risk of dying from this infection, which were very concerning out of China in particular. Especially also associated with surgery, but also concerned, could therapy play a major role here? This made everybody concerned, and we had no data from the US or really Europe to really advise us in a serious fashion how to advise patients in the era of COVID, especially also with concerns that medical centers might be overwhelmed. So this effort started. A very unique consortium was quickly brought together with our overall leader, Dr. Jeremy Warner at Vanderbilt University, with 5 lead institutions, with over now 11 members of the steering committee that's guiding this process to develop this massive database to answer key clinical questions, how to guide cancer therapy in the era of our COVID pandemic. So Dr. Warner is going to present at ASCO our first report, including already over 900 patients accrued in less than 2 months. Quite a remarkable feat that was pulled together thanks to the collaboration of now over 100 centers, especially from the US, but we do have a global presence. This early report has already Canada and some European patients as well. We're actively collaborating with the European Society of Medical Oncology that is also now helping us to gather data, and we're working on ways to collate this data as well. But this initial report, over 900 patients across all tumor types, both hematologic malignancies as well as solid tumors. Accrual was not restricted in any fashion in terms of tumor type, as well as patients did not have to be on active therapy. They could have had a history of cancer as well. We wanted to be sure we assess the risk really across the cancer spectrum, across the survivorship spectrum as well. Now this early report is more heavily weighted mostly towards patients with therapy or recent therapy, as those patients are more likely to be tested. But we are already getting a hint also how longer term survivors might fare as well. Our major findings were, we were looking at especially the impact on mortality. We also looked at the impact of the serious illness, especially serious hospitalization, and the results actually compare are nearly identical between the two major outcomes. We wanted to assess what are the major clinical risk factors that cancer patients have to really have a serious outcome, especially who are those patients that are at particular high risk to die from COVID among our patients with cancer. We've had hints from the general patient population what those risk factors might be, and we scoured the medical literature to really assess those risk factors to ensure that we particularly also assess those in the study and confirm or refute what might be the case for patients without a cancer diagnosis. What came out of this study was there are two major types of basic clinical risk factors that we've assessed that predispose cancer patients to have serious outcomes. Number one, these are basic clinical factors, and among those, it's particular age, gender. Men are at higher risk of dying, as well as having comorbid conditions that require therapy, especially an increasing number of comorbid conditions substantially increases your risk of dying from COVID-19, as well as smoking. Former smokers are at increased risk as well. We did not yet have enough patients that were actually current smokers, probably because many with a cancer diagnosis, fortunately, do stop smoking once they undergo therapy. Focusing on these non-cancer specific risk factors, these clinical risk factors that had been observed in the general patient population, particularly relevant also for our cancer patients. Every decade of age does nearly double your risk of dying from COVID if you have a cancer diagnosis. Among the comorbid conditions in the past, in the general patient population, we already knew that especially cardiovascular problems as well as diabetes clearly predisposes you to COVID-19 serious outcomes, as well as probably lung disease as well. What we found that similar to the general patient population, comorbid conditions unfortunately do predispose cancer patients for increased risk of death from COVID. And what we found is that not only cardiovascular problems or diabetics are at increased risk, really most major comorbid conditions that require active therapy, if there are multiple of those present in a patient, clearly predispose patients up to a risk of 2 to 5 times greater. So patients really need to be aware of this risk when they make their therapeutic decisions, as well as clinicians, of course. The gender question is really interesting, and there's some interesting biology that's being assessed, not in our study, but again, confirmed what has been seen in the general patient population, as well as age. And clearly, if you're above the age of 75, you have a substantial risk that needs to be taken into account particularly when we are discussing borderline effective cancer therapies with our patients, and that risk-benefit profile might change for our patients. So Dr. Warner is also going to tell us about the cancer-specific risk factors that we found, and particular patients with poor performance status, including a performance status of 2, which is a grading system that denotes someone who may not be able to work any longer, still can do self-care, and is up and about more than 50% of the time, but clearly their functional status has been affected from their medical conditions. Those patients are at quite a substantial risk. It's again probably a 4 to 5 times increased risk of having serious outcomes, and this will affect how we have to advise patients, especially once they have the infection. This is key for the medical teams to understand what those risks are. The other risk factor that cancer patients are exposed to is if they have progressive disease. That's not too much of a surprise. We already knew that patients with any type of infection who have progressive disease, it is very difficult to manage those. And the same is true what we found also for patients with a COVID-19 infection. So while we found increased mortality, in particular for patients with poor performance status, quite older patients and patients with major medical conditions, there is a good news story here. It's very encouraging news that if you're fit and don't have major medical problems, if you have a few to limited comorbid conditions, your cancer therapy should proceed with care, but we have not found any indication in a major way that care will substantially adversely impact you, which is fantastic both for patients as well as clinicians to know. As long as you can have a safe environment, which is the place for most, I would say probably all medical centers at this point in the US, as we've all adjusted to the new realities that this infection provides us with. What's also important to note is that these are early data. We have focused on 30-day follow-up data, as for most patients, we've not had longer follow-up than that, and for some patients we had less follow-up. To get to the full scope of the impact, clearly longer follow-up is needed, as well as what we need more patients in certain high-risk settings to fully understand the full impact of our medical interventions on cancer patients undergoing cancer therapy, especially the high-risk settings. We still require further understanding, in particular, how those patients are doing, how often does a serious problem occur for those patients. Overall, this is a very encouraging news for the cancer community as a whole. The early findings that general cancer care might not be possible any longer in the era of COVID for many patients is not a finding that we can confirm. The early reports were probably in a very unique setting, and we are very excited to report that cancer care in the US and hopefully most other places will be able to continue for most patients as it would happen without this pandemic going on. Taken together, these findings are really encouraging news for the oncology community as a whole. Yes, while we have found certain patient populations are at substantially increased risk of dying, the cancer therapy itself, even in these early days when we were still learning to figure out how to treat these patients, did not substantially increase the patient's risk. Our strategies that have been put in place in so many centers appear to really help patients to stay safe in this new pandemic era. And it appears cancer patients with care should be encouraged to proceed in most settings. There are certain high-risk settings where new risk-benefit assessments really have to be considered, especially if therapy might not be that effective or has a borderline effectiveness. But overall, this is very encouraging news and guides us to identify those patients that need particular intensive monitoring, care, and support through their cancer therapy. And CCC19 has really helped us to identify some of the most important early clinical findings that we could confirm in the largest database to date, assessing cancer patients with a COVID diagnosis.